This little award used to be the award we gave to Family Physician of the Year. And a few years ago when, boy, I feel like I'm channeling Dr. Cirillo. I was going to say when Dr. Snope was cleaning out his closet. But a few years ago when Dr. Snope found out that we were naming this lecture in his honor, he gave this back to us to display here. So we display it proudly at this lecture every year. To think about what he did for us. I get the distinct pleasure of standing in front of you every year at this time and not only introducing your keynote speaker at this lecture, but reminding you all the good work you did yesterday, for those of you who are here, and letting you know about some of the things that are going to go on in the next couple of hours here in Atlantic City. So, first, yesterday at our House of Delegates, we elected your new leadership. So if I call your name, and if you are in the room, which if you're not, you won't hear me, when I call your name, please stand up so you can be recognized, and we can play the graduation hold your applause game till we've gone through all of this. So the elections part of the day begin with our new officers, our President-Elect Maria Simonelli, MD, AAFP from Freehold, our Vice President Mike Cascarina, MD from Manasquan, our Treasurer Kelly Usry Kronhaus, MD, part of the BRIC takeover, which you'll hear about in a little bit, but from BRIC, New Jersey, our Secretary Sally Moravchik, MD from Hillsborough. In addition, you confirmed and will install tonight your new president, Lauren Carruth, from MD from Ewing, and by policy and procedure, Dr. Carazone, Peter Carazone, our board chair. We elected three new three-year board trustees, Vic Gupta, MD from Clifton, Ken Kronhaus, MD from BRIC, part of the BRIC takeover, Karen Lynn, MD, MS from New Brunswick, and we elected one-year trustee, Sean Cook, MD from Greenbrook. You elected a new physician trustee, Mariana Seneker. Boy, Mariana, if I just butchered that, I'm sorry. From Hamilton. You elected a couple old guys, Arnie Palais and Terry Schlimbaum for AAFP delegate and alternate delegate. And the residents elected their own. And this year, for those of you who aren't aware, the residents actually had an online election and elected Thomas Wall from Freehold. Then we debated three resolutions. You can read about those on your app and on the website. We amended and updated your bylaws. You should have read about that in Perspectives a few months ago, but we passed that. And then last night, right in this room, for the first time in 14 years, the residents from Virtua captured the coveted NJAFP Residents Knowledge Bowl Cup in a feat unknown to most humanity. They were awesome. Then last night, Dr. Cullen agreed at the last minute to present this talk. So you all know Dr. Cullen, and there is a lengthy bio. I will just tell you that the important stuff is that Dr. Cullen is a family doc from Valdez, Alaska. He's been a member of the AAFP for a very long time, since 1994. He is now currently the President-Elect of the AAFP. He joined us last year and proved once again that if you want to be the President-Elect of the AAFP, you must come to the New Jersey meeting. That's how you get elected to the AAFP. Dr. Cullen is in a small community in Valdez, about 4,000 people, Dr. Cullen, about 4,000 people. And he practices truly the full scope of family medicine. I think he's also the dog catcher. I'm not sure, but it's a very small community. I know he's the bear chaser. You'll find out about that in a little while. In addition to being the President-Elect and being an all-around wonderful guy, he's quite possibly one of the most fun guitar players picking bluegrass music you've ever heard. And if you come to the gala tonight and hang around afterwards, you'll hear some of that too. But with that said, Dr. Cullen, would you please come up?
Well, welcome, or good morning. This is a real honor to be back in New Jersey. I have to say, I really like your chapter, and I really love the people here. You've done amazing things in this last year, and I'll talk more about that tonight. But this is a really good group. I'm going to talk to you a little bit about frontier medicine. That's what I do. And this is a lecture that I give, I've been giving now to medical students and residents all over the country, as well as to, actually just last week I was in Washington, D.C., and I gave parts of it to HRSA about rural obstetrics. And so one thing I did want to say, though, is that I have a really broad scope of practice, and that's out of necessity. And but I have to say, too, that all of you could be doing this. It's just a matter of this is where I ended up out of residency, and then these are the skills that I developed, because that's what we do as family medicine. And family medicine is that we develop skills that are appropriate for our community. Some of what I'm going to tell you may be a little bit shocking, just to warn you, but this is the skills that we had to develop in our community. And that's where I live. That's Alaska. That's actually the pass overlooking the town where we go skiing. We don't have a ski resort. We have to climb up and then ski back down again. Yeah. There we go. So I'm going to talk. So frontier medicine actually has a designation. It's based on density, and we have a density of about 1 person per square mile, and then it also looks at time to get to a tertiary care center. And for us, the earliest we've ever been able to do it is about 4 hours. From the time we pick up a phone to the time the patient arrives in the tertiary care hospital is about 4 hours. If we drive, it's actually much closer to 6 or 7 hours. And then there's also a distance, because some places are very close, but they're hard to get to. Other places, it's actually very easy to get there. There's 105 points possible, and where I live, we have a score of 105. And I'm not sure if I'm not doing, there we go. And there's frontier communities all across the country. There are none in New Jersey, though. I learned yesterday that New Jersey has a population density of, was it 1,000 people per square mile? So we're at opposite ends of the spectrum here. Is that a laser too? There we go. And this is where I live, is right in here. And that's my house, which is nice, but except that we actually have a three-story house. And that's the hospital where we work. And the architect actually had a sense of humor. He was trying to make it look like a tanker. So the problem is that when you're talking about these rural communities, you have all the same issues that you do in a major metropolitan area. You have all the same traumas, you have pregnancies, you have surgical cases, you have critical care cases. But the issue is that it's really hard to go to the next largest hospital. And in the air transportation, whenever I talk to people who are in Washington, D.C., they think that, well, why don't you just get on an air ambulance and go? But air transportation for air ambulances is actually the most hazardous occupation, especially in Alaska. And we've lost a number of air crews. So that's actually more dangerous to be on an air ambulance crew than it is to be catching halibut in the Gulf of Alaska, like on the Deadliest Catch. And with all of that, then you have a limited medical staff. That's what Valdez looks like. That's where I live. That's actually looking pretty much from the parking lot of the hospital. But it looks like this a lot of the time. I don't know if you can see that, but those are skiers at the bottom corner. And sometimes it looks like this. This is 100-mile-an-hour winds at 0-degree temperatures. And then sometimes it looks like this. So this is, we had a lot of snow, and then it warmed up and it rained. We had an avalanche close off the road. And then to make it even worse is there was actually a river on the other side that filled up with water. So we ended up with this huge lake behind this, this dam. We started calling it the Dam-avalanche. That completely isolated us for days. And because they couldn't clear the snow because there was water behind there. And so they, luckily it got really cold, everything froze up, and then they were able to clear it. And that's the medical staff. So that's the, so we serve an area about the size of Ohio. And that's all there is. There are no specialists. There are no other providers. We do have a PA now, which is nice. We have a nurse anesthetist who's there some of the time, which is nice. But essentially, the entire care for this area is us. And so with frontier medicine, you still have all the same issues of staffing. You have to, every community needs to decide what they're going to do about, these issues about the staffing. Are they going to, staff with mid-levels? Are they going to have providers? I can tell you, too, that family medicine for us is the only specialty that works. And we've tried others. We've tried emergency medicine. We've tried obstetrics. We've tried internal medicine, even med-peds, and the only specialty that seems to work in our community is family medicine. And that's because of the breadth of training we have that allows us to do that. We have to provide anesthesia. We have to do the emergency medicine, so we also staff our emergency room. There's some interesting things about telemedicine that is making our job a lot easier. At the same time, there's a lot of dangers. This is another one, is that whenever you're talking to people in D.C., their solution for everything is telemedicine. And I was just at the President's Committee on the Opioid Crisis at the White House. And I went through this whole thing about how we have to take care of people who have substance use disorders, and that it takes a lot of effort and a lot of time on our part. And at the end of this about 15-minute presentation, his answer was, so telemedicine, right? And the problem is you need to have people out in these communities. That's the only thing that's going to actually take care of people. The other thing is that you have to deal with the politics. Small-town politics is pretty rough. And then I was going to talk a little bit about resiliency towards the end. And if you've seen one rural community, you've seen one rural community. Everybody is doing this different, but it's still the same things apply, that you have to cover the ER, you have to think about what you're going to do with your inpatients, obstetrics and surgery, and then outpatient clinics. That's something that we all have to deal with. And in terms of obstetrics, there are a lot of people that think that if somebody is pregnant, they should just go to a metropolitan center to deliver, but that's actually not what happens. Is that in these rural communities, women, when they're pregnant, will stay in those communities. And they do so because their families are there. Childcare is expensive under the best of circumstances. And so women who are pregnant have a tendency to stay in the communities that they live. And so if you are not delivering obstetrical care, you're going to be delivering obstetrical care, whether you want to or not. And then to make it even worse is that typically, even if you were to send somebody to a metropolitan area, you still end up having to take care of the premature labors, the complications, the gynecologic emergencies. And so we actually have really developed this so that we're providing full-scope family medicine in our community, including cesarean sections. Because on the other hand, if you're going to be offering obstetrical services, then you need to be able to do a cesarean section. And for us, that's really worked out well, because we can do cesarean sections, then that has improved our ability to take care of a lot of other things as well. And like I said, this is a community of 4,000 people. This is our census area right here. And like I said, that's about the size of Ohio. The thing about Alaska is that it's really big. So we like to tell Texas that if you cut Alaska in half, then Texas would be the third largest state. It's almost, if you cut it into 3 parts, then Texas would be the 4th largest state. Alaska is really big. So that's a big area that we cover. Despite that, our infant mortality rate in our area is 3.3 per thousand, which is less than national average. and actually less than a lot of the other communities in Alaska. And Alaska is doing well. And this is something else. You know, we were talking yesterday about just the funding of health care. We have an interesting situation here in that in Alaska that Medicaid pays better than Medicare. And we for years have had a program where all pregnant women could go on to Medicaid. And that, I think, is one of the big reasons why we're actually doing better than national average. But there's a lot of states that aren't doing as well. This is Nevada. So one of the problems happening across the country is that a lot of rural communities are losing all obstetrical services. And these are 2 counties just south of Reno that have infant mortality rates of 10 and 14 per thousand, which is well, basically twice, almost 3 times what is the national average. And the reason why is that they have no obstetrical services whatsoever. And like I said, what happens is that even if you're not providing obstetrical services, you're still providing obstetrical services. This is Mississippi. There are 2 counties that have infant mortality rates over 40 per thousand. And that's just unconscionable. That's worse than a lot of third world countries, and it's for the same reason. There's a lot of issues with poverty, with minority health, but a lot of it is that there is nobody providing obstetrical services in the entire county. Oklahoma, the same thing. And this is why we do it. So these are twins that I delivered. I had no intention of delivering twins. That was my plan. But like I said, sometimes you don't have that option. I've delivered now 2 sets, and this was one where I saw her on Friday. We knew she had twins. She was 31 weeks. She was going up on Monday to Anchorage to stay for the rest of her pregnancy. I saw her on Saturday, and at that point, she had some feelings of pressure. We checked her cervix. Her membranes were hourglassing through her cervix. She was already dilated to 7. And to make matters worse, the amniotic sac was full of cord. So if she had ruptured, then we would have had a cord prolapse. And this happened in the middle of a snowstorm. That's the typical case. And so we had to keep her pregnant for another 12 hours until I could get a neonatal team into the community. That was how long it took before the weather broke. But we did a cesarean section in Valdez and delivered healthy babies. And the really cool thing about living in a community like this is that I get to see these kids grow up. And there is nothing that equates to the feeling you get watching kids that you've delivered grow up in a community. And so then the question is how do you do this? How do you do something like a cesarean section? And we end up doing a lot of our own anesthesia. We do have a part-time nurse anesthetist. He just comes in periodically. That's new. So for 21 years, we didn't have anybody. And so we do a lot with midazolam and fentanyl. So when he's around, we use propofol, but I have to admit, I just hate injecting a medication that looks like milk into people's veins. So I try not to do that. It's great. Midazolam is a great who uses midazolam, like with kids? Because you can inject that nasally, just a little bit at a time. I always just do just a tiny bit at a time until to the point where I can, if I'm in the ER and they have a laceration, that I can sew it up. Since I live in a small town, I don't want them to be afraid of me later on. So it's great to have a medication that they won't remember what happened. And it's interesting is midazolam is an incredibly safe medication. What I usually use is 2 milligrams, and I just keep doing it every 5 minutes until I get to the point where I need the person to be. The most I've ever used was 68 milligrams. And my partner has gone actually much higher than that. And we've actually done an appendectomy on midazolam before, so it's a great medication. As long as you're not mixing it with the fentanyl, you don't see very much of the respiratory depression. This is just my own personal experience. I had somebody who had a miscarriage at 12 weeks, and just going from the ER to the OR, we ended up losing 1,000 mils just to get there. And when I was getting ready for the DNC, I grabbed one of my partners on the way back and asked her to give 2 milligrams of Versed while I was getting ready, and the patient was completely relaxed and really pretty much unconscious, which I thought was great. And I went ahead and did the DNC and stopped the bleeding, and everything was good. And when I looked up, though, her eyes were just incredibly wide, and she said, "I just gave 20 milligrams of Versed." And it was fine. It really was. There was no issue. So I can't say it's always smooth sailing, but it's one of those great tools to have in your pocket. So for cesarean sections, you really do need to do a spinal, and so we don't do when we're delivering babies, we're not doing epidurals. In fact, I had never delivered a baby with an epidural until 3 years ago when the nurse anesthetist came on. Instead, what we do is an intrathecal. And intrathecal anesthesia is actually a family medicine procedure. We're the ones who developed this. It was the only really good articles are in the AAFP journal. And basically, what you're doing is this is a spinal, but you're injecting Duramorph and fentanyl. And so it's just only the narcotic component that you're injecting. And the advantage is that it's really quick, it's very safe. It takes me 5 minutes to do this. This is just like doing a lumbar puncture. And I have to admit that I feel very comfortable doing lumbar punctures, but I'm the last generation that did a lot of lumbar punctures in residency because the Hib vaccine came out my first year of residency. And then that was it. I mean, we just don't do that many anymore. So this is a way to keep our hand in. And we do a lot of these. It's very effective. It's the same technique as doing a lumbar puncture, but you don't have to have as much staff to administer this. And it takes an hour to get an epidural up and running, at least where we are. Is it quicker here? It takes us a long time, but it takes me 5 minutes to do this one. And the downside is that it has a fairly short window, and so you have to kind of plan and time this about when you give it. Everybody itches, and the itching is a good sign. That means it's working. And so when people are complaining of the itching, you just say, well, they're itching. That means that they're not having any pain. And there's always a risk of infection, although I've never seen it, and the risk is very low. The risk of spinal headache is the same as doing an epidural, and there's a risk in the literature about respiratory depression, and if you talk to anesthesiologists, they'll always talk about the respiratory depression. It's actually incredibly rare. In fact, there was a study of almost 2,000 women. They had one that had oxygen saturations that were dropping below 90, and she received naloxone. So this is something that actually is very safe. But the thing is, because we can do this, then, and this is just the procedure. So like I say, it's just half a mil of fentanyl, half a mil of Duramorph. We use a pencil tip needle rather than a regular cutting needle for the LP. It's a 25 gauge, so it's very small. And it's so bendy you have to use an introducer with it. But otherwise, it's exactly the same technique as doing a lumbar puncture, except that instead of taking CSF out, you're putting the medication in. I always use a ballpoint pen to mark the skin. You just retract it, and then you can push down. This is a great technique, by the way, if you're ever doing any procedures in the office, is you just push with a pen, with the pen retracted, and you get a nice circle that lasts for about 20 minutes. And so even with betadine, it's just a great technique that I use, and that's the result. I mean, it's something that just works incredibly well. And the advantage is over epidural is that she can get up, walk around, take a shower, deliver on her hands and knees. I mean, there's no weakness whatsoever. You just don't have any pain. But the thing is because we can do the intrathecals, then we can also do spinal anesthesia. And the only difference is that we use bupivacaine instead of the Duramorph and fentanyl. Otherwise, it's exactly the same procedure. You have to watch out and make sure that the person is hydrated, that that you have IVs all set up that if they're heavy, you want to use less medication than if they're thinner, because the adipose tissue is also around the spinal cord. If you inject fast, you're going to get a high level. And if they cough in the middle of it, you can expect that too. And the problem with the high level is that people feel like they just can't breathe. They're breathing fine, they just can't feel it. And so you have to really talk them through that. There's always a risk of low blood pressure. There's a lot of ways to take care of it. You can take care of that with medication. What we used to do is just lift up their legs. That was one of my jobs, actually, when I first got to Valdez, is to hold the patient's legs on my shoulder until their blood pressure was stable, and then that worked. That actually worked just fine. But because we can do spinals, then we can do appendectomies. And that is something that we're doing less of, because the medications, the antibiotics now for appendicitis actually work fairly well. And you can use IV antibiotics, stabilize somebody, and then have them to have an elective appendectomy at some later point. You don't actually have to remove appendixes the way we used to. But we've removed a lot of appendixes, especially when there wasn't any other option. And we've had a very good success rate of that. It also opens the door as far as taking care of ectopic pregnancies. And that's something that you just never know when something like that's going to happen. And I have to admit that that's one of the scariest things that I've had to deal with is ectopics. I had one where I had this young woman who had already lost one tube, and she really wanted to be pregnant, and she came in with an ectopic. I really wanted to not do the surgery, obviously, but she was just at the edge of where she was bleeding. So we treated the ectopic medically, and then we had a surgical team that basically sat at the bedside for 3 days until the weather cleared, because it was right in the middle of this huge storm. This is, like I say, this is a recurring theme. So 3 days, it was just this unending storm. And finally, we don't have a Catholic priest. We're too small to have a Catholic priest in Valdez, but we had a nun, Sister Marie Brent, who was just awesome. She also volunteered for the fire department. But they asked Sister Marie to come in and pray, and within an hour, the weather was clear. It's like, if I had known it was that easy, I would have had her come in the first day. We would all had a lot more sleep. So we also have to take care of the emergency room. And it's sort of a unique environment. It's we've had to take care of quite a few cases of hypothermia. We do our own ultrasound as well. And ultrasound has gotten so good. I mean, this is a skill. If you want to pick up something that's really fun, I would pick up ultrasound. And because that's, the technology has gotten to the point where there's a probe that actually attaches onto your phone that has really decent quality ultrasound images. And it costs $200 a month to rent this, to lease it. And you can use that in all sorts of situations, but we use ultrasound a lot. I was going to talk a little bit about intubation, because that's something that, again, the technology has really helped us quite a bit, and then transfer. So I've actually brought back now 2 people with a core temperature of 75 degrees. Before it was 84, that was my lowest, and I was feeling pretty good about 84, but then I had 2 back-to-back that were 75. And some things just to kind of think about is when you're assessing somebody, and this is true even not in an emergency room, but if somebody is not shivering and they're cold and their core temperature is already below 90 degrees. And the thing that really kills people with hypothermia is the afterdrop. And so what happens with afterdrop is that you have all this cold blood in your arms and your legs, and one of your mechanisms that your body does to prevent hypothermia, or to prevent further worsening of condition, is it shuts down circulation. And so you end up with these pools of cold blood. If you warm somebody up inappropriately, all that cold blood ends up back in the core, and it actually drops the temperature. We had one guy that he was actually a high school kid, but when I say kid, I say that he was actually over 300 pounds and taller than I was. All-state linebacker from some state, but just huge kid. who fell through an ice bridge on the glacier into a crevasse and fell about 50 feet before he stopped. Ended up stuck like a cork in a bottle, upside down, 50 feet down. And it took us 8 hours to get him back out again. And so when we did, you know, he was the one that had a core temperature of 75 degrees. And so when we started warming him up, we didn't warm up his arms and legs. I kept his arms and legs completely out. We warmed up his core. We used hot air blankets. We used IV bags. You can do warm IV solution as central as possible, although anticubital is fine. We use warm air mist and with that, but the nurses hated it every time when they saw his arms and legs sticking out, and so they would cover him with a warm blanket, and as soon as they do that, his core temperature would drop again, and so we'd have to uncover him, and it would start to creep back up. There was a story in Alaska about there were 5 fishermen who went down with their fishing boat, were rescued by a freighter who then put them into a hot shower room and turned up the hot water and actually killed them. And it was just for this reason. Because the other part, so there's the after drop. The other thing, though, is that there's something called cold diuresis. And cold diuresis is if you're constricting all your veins and your arteries because of the cold, that you end up with a fluid overload in your core, which means that you end up diuresing. And people become extremely dehydrated when you start warming them up. And so for the one patient that we had to warm up from a 75, I ended up giving him 8 liters of fluid. And their metabolic rate really slows down. That was the really cool thing is we had a CO2 monitor, just a great invention, and with that we were bagging him because I had to intubate him, and we were bagging him, but to keep his CO2 right around the 30 range because he also had a head injury. But to do that for his metabolic rate, we were bagging him 4 times a minute, and we could just watch as he warmed up, his metabolic rate increased, especially at around 90 degrees, because at 90 is when insulin really starts working again, and then at that point his metabolic rate really increased. And then the other thing is that below 84 degrees is they really are likely to go into ventricular fibrillation. Sometimes just bumping the bed hard is enough to do that. How our rescue team got him off of the glacier without him going into ventricular fibrillation, I have no idea. But it's just one of those, that was this heroic save, because they had to go down into this crevasse to get him out. He's stuck in a nice constriction in this crevasse, and I think I have here we go. So these crevasses can go down thousands of feet, and so he hung up 50 feet down, but if he had not stopped there, then he would have gotten probably another 1,000. And when people are cold, at 90 degrees, they start getting really confused. This is it's supposed to be a picture of confusion. That's actually, I took a picture of my son that was through the wall of a crevasse, so that's about 4 feet of ice, and just incredibly clear ice. And when people are cold, around when they drop below 90, is they also do something called terminal burrowing, and they start to crawl into places to hide, like culverts and stuff. And so if somebody's really hypothermic, you actually have to go look for them, because they'll be trying to stay warm. It's just one of those primitive reactions. They're not thinking about it, but they'll crawl under leaves, they'll crawl into culverts. So this is my other son who's demonstrating terminal burrowing. And I had my own experience with hypothermia, and that it was really cold. It was and blowing really hard. And by cold, I mean down below 0. And my wife and I decided to go hiking up this canyon that normally you can't access because it's full of running water, but because it was just ice. And we were wearing snowshoes, and I hate snowshoes. It's just one of those things. And so at some point, as we're walking on this ice, I decided to take my snowshoes off. My wife, of course, says that was a very bad idea. Being a typical husband, I said, no, it's okay. I know what I'm doing. And promptly broke through the ice. And And so then had to hike back out, which we did in a hurry. But it definitely, it's interesting, that whole process of hypothermia. And the thing is, for a lot of it is that, this is the top of a glacier. This is what it looks like. But then that's what it can look like from underneath. And so you have these crevasses that are just, kind of holes. As long as the snowpack is on top, it's good, it's fine. But if it's, but you could be walking over these things. And so when we deal with hypothermia, we warm people up either slow or medium or fast. Slow is basically just letting people warm up on their own, but that won't happen if they're below 90 degrees, because at that point they're not shivering. And shivering is the body's mechanism to warm up. And so if they're below 90, you have to figure out some other way to warm them up. We do a medium rewarming, and what we do is we actually put a catheter in an EEG tube and just pour warm water through those to heat people up from the inside. You can do deep peritoneal lavage, and that works, but this seemed like it was easier. It took us about 8 hours to warm our patient up that was down to 75 degrees. And just watching him very, very closely, just to make sure he didn't go into ventricular fibrillation. I also found that when you're intubating somebody who's really hypothermic, the medications just last forever. So we gave 1 dose of succinylcholine, and it lasted for 8 hours. Ultrasounds. We've been doing fast exams for a long time. You're just looking for collections of blood in the abdomen. It's very easy. We use ultrasound for vascular access, and that's an amazing, it's just an amazing use of the technology. Is that you can see the veins, you can watch the IV going into the vein, and somebody that you just can't get any venous access, it's just a great way to do it. Ultrasound has revolutionized the treating ectopic pregnancy. I still the generation where we had to do choldocenteses to see if there was blood in the cul-de-sac, and this has just made things so much easier. And like I said, if you want to pick up a fun skill, that's a great one. And right now, family medicine residents across the country are learning ultrasound techniques, and I think that. Putting on my academy hat here for a moment, I think that's a technology we need to own. That's a disruptive technology we can use on our offices, and it's not something that takes that long to learn, and it's just really fun. It's just something that breaks up the day, and it's a fun technology. Something else I've learned is that with intubation, there's something called a bougie, which looks like that. It's just this long, flexible rod. With that, and there's optical laryngoscopes where you can look at, it's like a closed-circuit TV camera, just like the cell phone technology, where you can look down at the end of the laryngoscope. The combination of those two, you can intubate anybody. And so this is something that a lot of people are really worried about going out to rural communities, and it actually it has become so easy to do this, that you can intubate anybody in a rural community now. 400 or 500 pounds, no problem. I had one patient that it was the first application I've ever seen of a neck tourniquet. We used to joke about those when I was in residency, but I actually saw one. It was somebody that he was really angry at the police, and so he stabbed himself in the neck and had a lot of neck swelling. And so they put on a C-collar and cinched it down tight. Actually, it worked just fine. But then intubating him was really a challenge. And so we had to use that optical laryngoscope and bougie. So this is my kids when they were little. It was really interesting. When we would go sailing in Alaska, that's an orca coming over to check out the kids. And that used to happen all the time when they were small. They don't come over nearly as often. I don't know if that's because they were curious or hungry, but when the kids were small, they used to come up to the boat all the time. So fish hooks. Does anybody want to know? Does anybody have any great techniques for removing fish hooks? So this retrograde and remove, this never works. So I do a lot of fishhook removals, 2 or 3 a day in the summertime. It's just one of those things. And this is the easiest technique And if the hook is not too big, this works really well. I never do it, because typically I see people in the emergency room for a fish hook. We also see them in the clinic, but you know, if I remove a fish hook from somebody in the emergency room, it's going to cost them $600 or $700, and this is so quick and easy that they feel really cheated. But basically, you just tie a string around the curve of the hook, and you push down on the shaft and then pull it right out. I mean, it just pops right out. This is, you can use dental floss, you can use thread. I mean, there's all sorts of things. This works incredibly well. But I never do it, like I said, because I want people to feel like they really got treated. And so I do this, which is actually a technique that, that I developed on my own years ago. But basically, it looks so much more sophisticated than the tie and yank. And what you do is just cover the barb with the needle, the hole inside the regular needle. And so you have to use a bigger needle if it's a bigger hook, right? But other than that, you numb up where the puncture wound is, and then you just follow the hook down, or the hook down to where you get to the barb. You cover the barb with the hole inside the needle, and then you pop out the hook. And this only takes me about 15 seconds. It's actually quicker than tying a string around the curve of the needle. And this works incredibly well. But it takes a little bit of learning how to get to that point. You have to free up tissue around the base of the barb. And admittedly, you know, we have really big hooks, right? Because we've got really big fish. When my daughter was little, we were in San Diego, and there was somebody there who had caught a bunch of estuary perch, and he very proudly held them up for her to look at, and she said, "Man, what are you going to catch with that bait?" But sometimes you just need to advance the hook and then cut it off. I mean, that happens. I had a kid that got hooked through the nose. And usually when it's never somebody who hooks themselves, right? His buddy was fishing and reached back and on the back cast just hooked him. And then thought he had hooked into some bushes and just kept on yanking on the pole. And the poor kid was saying, you know, he couldn't get out the words, "You've hooked me through the nose." He could only go, "Ah, ah, ah," and so he ended up getting pulled a whole bunch of times. He said he was never fishing again because he knew exactly what the fish felt like. And like I say, sometimes you just have to. But this is actually really hard to bring it through the skin again and then cut it off. The skin is amazingly tough, and it's just really hard to get that hook again through it. So it's much better to back it out if you possibly can. I don't know if Teresa's here, but we were talking last night about being attacked by halibut, and I did have a patient that came in with shoulder pain, and when I had him take off his shirt to take a look at his shoulder, he had this circumferential bruise around his bicep, which I couldn't figure out where that came from. The story came out that he was fishing for halibut, and the halibut in Alaska get really big. I mean, we're talking, you know, 300, 350 pounds, and we have a big derby, so that's the big thing, is to catch the biggest halibut. And apparently he caught a really big halibut and brought it up to the boat. And when you have a big halibut like that, you actually have to harpoon it. It's not something that, you know, you have, because it's just is so big. And they were just in this little tiny dinghy, just a two-person dinghy. And his buddy harpooned the halibut, and then the hook fell out of the halibut's mouth as it dove. When they finally got the halibut back to the boat, they realized that the harpoon was just barely in, and they were going to lose this fish, which was the Derby winner. He was absolutely sure of it. And so he had this brilliant idea that he would reach down and hook the fish through the gills while it was close to the boat, just kind of sneak it in there without the fish knowing he was there. But unfortunately, what happened is, as soon as he got his arm down to hook it, the way the halibut feed is, they just open their mouth up really big and they just suck everything in around it, including fish and whatever. And so as he got close, it all of a sudden opened its mouth really big like that and sucked his whole arm all the way up to his bicep, and then clamped down on him and dove for the bottom. And so he was holding on to the side of the boat while this fish was trying to dive to the bottom. And he realized that he was gonna die, that this is it. And but not only that, but he was going to kill his friend too, because the boat was about to capsize. The water's really cold, and so he just totally relaxed and just let it go. But when he did that, the fish let go of him, and dove for the bottom. And they ended up being very shaken but alive, and the boat was still upright. The round side was down, and so everything was good. And then, but they were a little bit bummed that they had lost the fish. And then, as he was starting to reel in the rod, he realized he had actually hooked it. So he brought the fish in. Telemedicine, we use a lot of telemedicine, and the way that telemedicine works best, and this is from, again, family medicine perspective, is for us to use it in our offices to contact specialists. I don't think that telemedicine is the way to solve the rural healthcare crisis. It really works best if we use it. Although I have to admit, the first time we have tele-ICU, and as I was taking care of patient at 2:30 in the morning, I didn't even know that it had been hooked up. It had been sitting there in our one critical care room for a couple of months, and I had somebody that was decompensating at 2:30 in the morning. Apparently, one of us had bumped into the machine and turned it on, which I didn't know about. And as I was getting ready to intubate, because she was a patient with COPD, was getting worse, I heard this deep voice say, looks like she's decompensating. And I'm looking around, it was just me and my two female nurses, and it was 2:30 in the morning, and then the voice said, "You might need to intubate." And I'm looking around, and I can't figure out where this voice is coming from. And then when he said that the propofol might be a good idea, then I realized that one of us had backed into the telemedicine card and turned it on. So politics. So one of the other things that, and the reason why I'm doing what I'm doing right now is that when I moved to Valdez, and I was just out of residency, so this is my first job out of residency, I immediately found myself immersed in politics. And what I found is that as family physicians, if we do not engage in politics, then we just get taken advantage of, and that's something that we all have to do. And that's what I ended up doing in my community. The problem is that people making decisions about healthcare really don't have any idea of what they're doing, and that is something I have found to be true throughout all levels of government, everything from the town of Valdez to Washington, D.C. They really don't understand it, and so if we're not there showing up and telling them what our patients need, then they're going to make decisions that are flawed. And so we have to be involved in this arena. I'm sorry, I wish it wasn't that way, but it is. And that's what I learned in Valdez, was that that we had to take control of the debate, and we did. But I also found that if we talk on behalf of ourselves, that does not work. We can't talk about how much money we're making, and we can't talk about how many hours we work. We have to talk about it in terms of our patients. And because we all have stories about our patients who don't get their needs met because of the way the system is. And that it's one of those things, if we can talk on behalf of our patients, then our voice is amplified. But if we talk on behalf of ourselves, it just gets a little bit diminished. And that's just the reality. In a small town, it's very clear that whenever I speak, everybody hears it from the perspective of the town doctor. And so I have to be very clear about my message. I don't talk about the ski trails. I don't talk about the fishing derby. I only talk about medical issues. And that's just something, and I think that is also true, almost regardless, that just staying on message in politics is incredibly important. Because when politicians hear a physician talk about something else, there's a cognitive dissonance that they just don't seem to listen. It's really important to have a strong medical staff. That was something else I learned, and that's one of the things I really worry about right now, is with so many employed physicians, is that medical staffs get subsumed into this employment model. And it's a three-legged stool, right? It's the hospital administration, it's the medical staff, and then it's the hospital board. And it's the three equal partners. And if it's not like that, then there's problems. And I've seen that happen all over the country. And then, in a small town, you can't have any indiscretions because everybody's watching. And so I think really long before going to the store and buying potato chips. That just... And resiliency, and I'm kind of out of time, but I'll just finish up real quick. But in terms of resiliency, there's something, because working where I've worked for the last almost 25 years, there's definitely times that I've gone through burnout. I mean, that's just, I think, inherent in what we do. But having a sense of agency, having a sense of control over our destiny is absolutely important. That's a huge factor in terms of resiliency. And if you feel like everything is being done to you, that means you've lost that agency, that sense of control. And the other thing, too, is that I have to tell you that if you feel like you're in a horrible situation and that there's no options, there are so many options. Family medicine is the most sought-after specialty right now. You can get a job anywhere. And it's part of the administration's job is to make you feel like you have no other options and you have to accept whatever deal it is that they have for you. And that's not the case. You can go anywhere, and there's so much need for family physicians. Having a mission, our mission is easy. We take care of our whole community. And I see that every day. Going into the store, I see all the kids that I've helped deliver, or people that I've saved from various things. And I can just see that right around me, which really makes a big difference. Exercise, got to exercise, especially when you have a horrible case happen. You have to get out and exercise hard, and that means more than a walk. That means getting your heart rate up to 80% of maximum and holding it there. Mindfulness. I gave a whole talk about this last year, so I won't go into that too much, except that it's something else to be really conscious what it is you're doing and then not let yourself be pulled along by the currents of what's happening. And empathy. And that's, as family physicians, that is something that we can provide our patients better than any other specialty. There's a study that you can actually predict who is going into family medicine based on their empathy scores before they start medical school. And this is something that we can provide better than any other specialty, and that's something that our patients absolutely need. Any questions?
Actually, I'm very impressed by the low infant mortality rate that you quoted. In New Jersey, no one's doing OB in primary care. It sounds like your rates are better than New Jersey's. We have this many specialists, this many primary care. Do you have any concept, or does AAFP have any concept of what the right ratio to get the best outcomes in terms of primary care to specialist ratios?
Yes, so we want 25% of physicians doing primary care by 2030. And I think that regardless, that's going to happen, and it may even be worse. And the reason why I say that is that with the extent that healthcare costs are rising in this country, at some point we're not going to be able to afford the specialty care as it currently is. And the only way forward, I think, in order to reduce costs, because we know that for every dollar spent on primary care, you save $15 or $13 overall to the healthcare system. The only way we can go forward is if we have a predominantly primary care system. And that's something that's true in other industrialized countries. We spend twice as much in our country on healthcare as any other industrialized country. And why is that? Well, it's not the utilization, because our utilization is down at the lower end of the spectrum of industrialized countries. A lot of it is administration. We spend 4 to 8 times as much on administration as any other country. But the other part is that we are incredibly anemic on primary care. So most states have a primary care rate of about 5%, and it needs to be at least 15%. If we're going to see those cost savings. And so somewhere between that 15 and 25%, I think is 15% of all health care being spent on primary care, and I think that 25% of physicians need to be in primary care. Yeah, the system we have now is absolutely top-heavy. It doesn't make any sense.
How did the gentleman with the 75 core temperature do?
Well, okay. So it took us a long time to get him warmed up. And we knew he had a basilar skull fracture because he also was leaking some CSF. I wanted to figure out what temperature to send them, right? Because there's some studies that show that if somebody is hypothermic, or if they have a head injury, and you ship them hypothermic, they actually do better. And so I called up a neurosurgeon, and I said, listen, I've got this guy. His core temperature is now up to 80 degrees, and we're warming up. At what temperature should I transfer him? And the neurosurgeon says, well, you know he's dead, don't you? And so I hung up on him and called up somebody else, because that wasn't even worth my time. And so I called up a pediatric intensivist, even though, like I said, he was 300 pounds. And I went through the whole thing, and she said, God, I have no idea. But she said she would come up with a brain trust, and we'd figure it out. And we decided on 93 degrees. That 93 degrees would be the appropriate temperature. Just pulled that out of a hat. And he came back and saw me the next year, and I really should put that slide in just to show how big he is, because he went back in school. They wouldn't let him play football the next year because of the basilar skull fracture, but I understand he's playing now. He has some nerve damage to his left hand, because that's how they got him out. They couldn't pull him straight out because he was wedged in so tightly. They actually had to tie a rope around his arm and pull him sideways to get him out of the crevasse. And so he ended up pulling him out of there by his arm. But outside of that, yeah, 100% recovery. I get a Christmas card from him every year.
Yeah, I was going to ask about how do you mint more family doctors? Because I have a big private practice, and I'm a chairman of family medicine in a community hospital. And one of my fantasies, which I don't have the skills to do, would be to start a residency, because our little community hospital has a peds, internal medicine, OB residency, surgical residency, and there's politics and all this other business. But I have a space where you could put a bunch of family medicine residents, and so my fantasy, which is it's a dream, it doesn't exist, it's not a goal with ways to do it, is to start a residency out of my practice, so I have a legacy from my 5,000 patients in central New Jersey. But I don't know how to go about that. So if you could have somebody speak to me later about it, or give me some ideas now about how the academy can help mint more family docs, because that's what we need in our area. Because in my department, as the chairman of family medicine, if there's 25 docs, in 5 years there's going to be 5 docs less, because everyone's retiring, because everybody's in their 60s and beyond.
Yeah, and there's actually a few things in that question. One is that we do have a shortage of family physicians. It's dramatic. It's going to be a significant shortage. We're looking at they're going to be down about 30,000 within the next 10 years. That's just because people are retiring, and because the baby boomers are getting older, and that's what we're going to need. At the same time, our medical students, we're getting more and more medical students, even in this country. So the osteopathic medical schools are really increasing their class size. And so in 2 years, we're going to have a bottleneck between the amount of medical students who are going to be graduating and the number of residencies that we have available. So we definitely need, so if you can create a residency within the next 2 years, that would be awesome. How to do it? There's 2 ways. One is there's a stop on all residency monies at this point for hospitals that already have residency programs. And that's something the Academy has been working really hard on, is to defund fellowship programs and instead put that money into primary care residencies. That's one of our big pushes. So far we haven't had any traction with that at all. But the other way is if you can create an FQHC, some sort of, like an FQHC, you can create a residency within that.
What's an FQHC?
Federally Qualified Health Center. And so there are rules about that, but especially if you're working with an underserved population, that's a possibility. And with that, then you can create a residency that has money completely separate from the regular American or the Association of American Medical Colleges system. And there's actually a lot of grants right now for that as well, for startups. There was a new $20 million grant that just came up for starting family medicine residencies. But I think it's going to be hard to do it in a hospital that already has other residencies. So probably in your case, they're called teaching health centers. And you base them out of a community health center kind of approach. And those are really effective. They're less expensive to run than a normal residency. You're out from under the administration of the hospital, because hospitals don't understand family medicine. And so they're always saying the family medicine residencies cost them money when they don't. But they cost shift to the point where they can tell you that it's a huge expense, not taking into account all the things that family medicine residents do for the hospital, including having patients. So there are some real advantages with that. The other is that for teaching health centers, the residents have a tendency to stay in the communities more than with regular residencies. And so if you're trying to attract physicians to a community and have them stay, that teaching health center program seems like it's extremely effective. Right now we have 750 residents across the country that are in teaching health centers. All right, anything else? Oh, can you play that clip? This is for Ray. And I told this yesterday. So I had not my patient, but a friend of mine, Paul Zimmer in Kodiak's patient, was walking through the woods in Kodiak when all of a sudden this bear came charging out of the brush, knocked him over, and stood there with her paw on his chest, holding him down. And he wasn't hurt, but he wasn't about to move. And she waited until her 3 cubs walked by, and as soon as they were past, she lifted up her paw and walked after them. And that's what I want our academy to be. I want the academy to be the bear. So that's what you're going to see. It's going to be much more aggressive. All right? That's our backyard. Those are good. And that's the mama, right? Because if you see cubs, you know that there's a mama there. What I didn't show is her coming up and checking us out. I didn't want to spook her at all. But it was interesting is talking about relationships, I've been running into those bears all summer long, and I'd be riding my bike and they'd be on the bike trail, or I'd be riding by and they'd be in the field next to it. And I always let them know, you have to let bears know that you're there so you don't surprise them. And so I would sing the bear necessities because they seem to like that. And so when they came into the yard, it was just like, hey, just neighbors. All right, well, thank you very much.